Okay, good afternoon, class. Today we're going to go over salad innovation, the technique used for innovation to clean up the soiled airway for better visualization of the vocal cords. My name is Bryce Smith. I'll be your instructor today. If y'all have any questions or anything like that, just feel free to butt in and ask me, and I'll answer. So let's talk about the innovation tools that we use for innovation. Obviously, we have our learner scope handle. In the mornings, during your morning check, especially on the ambulance, you want to check to see if that light works. We have the correct size learner scope blade that will, this is a size for an average adult. We'll need the ET tube. For the ET tube, you'll need a 10 ml syringe to fill this bulb up. You got your bougie or stylet. It's up to you, whichever one you would prefer to use in the innovation setting. Let's see, we got the tube tamer. That'll help keep the tube in place. Obviously, everybody has that general knowledge of what these tools are, but we're just kind of reviewing these tools. Very important, to me at least, we need a CO2 monitoring device. This is the inline CO2 monitoring device that plugs into specifically our Zoll monitors, and it can read capnography and waveform capnometry. We have the color metric here whenever you deliver breaths, and it will change colors to let you know that you are in fact in the trachea and not the esophagus. We also have a rescue pod. We use rescue pods at our agency. You could use any sort of device such as this one. I also put nasal cannula on here. This is mainly for pre-oxygenation. Before we intubate the patient, we're going to try to dump as much as that oxygen into the oropharynx before we deliver breaths with our BVM here. The BVM, of course, OPA, to open the airway to pre-oxygenate the patient. We also have a C-collar that's optional as well. That's up to you. This also helps keep the, after intubation, the airway midline, to keep it from dislodging or anything like that while we're making a transition from the ambulance into the ED, things of that nature. It's a really good tool. If you ever think about using it, I'd recommend using one after your intubation. And most importantly, for this specific lecture, we're going to go over the suction. This is a portable suction that we would generally use for pre-hospital setting. We have our suction tubing canister. This is the Yonker. This is the Yonker we'll be using with the salad technique. And we'll also have this is a 14 French soft suction for suctioning out the ET tube, more specifically the airway after the intubation. We'll be using that. And last but not least, our oxygen. We have a D-tank here with a oxygen. Hook up our oxygen, and we just need high flow O2 for the patient. And that's I believe that's all the tools that we'll be using for our innovation. Can anybody tell me any tools that I might be missing or that you can think of? No, nothing that came off the top of my head. Pretty much covered it all right here. These are, it's a lot of tools. Most importantly, before you get started on your innovation skill, you want to put all your tools together. I like to put all my tools together and stage them to the side to where I know where they are, and I like to usually put this around the patient's neck and get it ready before I intubate. we'll go over that here pretty soon. Let's talk about some the anatomy right quick. Just a little review. This is our goalpost right here. This is what we're aiming for. These are the vocal cords, and this is the trachea right here. This is where we're trying to hit. Obviously, I got a little animated picture right here that goes more in depth with the anatomy, but you got your vocal cords, your epiglottis up here, and your trachea right here is what we're looking for. Basically, if you can't see this, don't try to advance the tube. We'll go over soiled airway in cases where vomitus, secretions, blood, or anything of that nature might be covering this up. And our goal is to suction all of that out in order to visualize this right here. Any questions on the anatomy? Everybody knows what they're looking for when they're getting in intubation. Okay, so let's talk about intubation criteria. So these are some cases where we can basically a patient would be eligible for intubation. Respiratory risk, compromised airway. What kind of compromised airway am I talking about here?
It could be a fractured, excuse me, a fracture to the upper airway.
Fracture to the upper airway, compromised airway. Really anything that would not be sufficient and patent for the airway, such as it could be an overdose with low and slow, shallow breathing, hypoxia, things of that nature. Impending laryngeal spasm from toxic inhalation, anaphylaxis, drowning, etc., things like that. In those situations, you might want to think about intubation fairly early because you know that in these cases, more specifically, you might deal with closing off of the airway. And that's more of a obstruction, but when it gets to that obstruction point, it's a little too late at that point. So I heard a lot from old school medics, GCS less than 8 intubate. Now I think personally, that's kind of old school. I don't think that every patient should be criteria for if they're less than 8 GCS, just automatically get intubation. So I believe that patients should meet certain criteria in order to intubate regardless of their GCS. So first I want to go off patient presentation. How are they presenting? Are they hypoxic? Are they not circulating too well? Things of that nature. Vital signs. I want to take a good set of vital signs, especially respiratory rate. If it's between 12 and 20 and their GCS is less than 8, I don't know that I'm necessarily going to intubate at that point because they're able to protect their own airway and breathing normally, within a normal range at least. I want to get a current history, events leading up to the current condition of the patient. And last but not least, GCS, of course. Not just the GCS, but I'm going to factor in all of these things before I go ahead and intubate a patient. You could have a patient that's a GCS of 3 with perfect vital signs. They're not hypoxic. They're satting at 100%, and they're breathing at possibly 12. That could be an overdose that's not quite respiratory depressed, but you'll come across that, and that doesn't necessarily mean that the patient needs a tube right away. So supplemental oxygen maybe, and monitoring of that airway. So now we're gonna watch a quick video. I say quick, it's a little long, but I fast forwarded it so that we can watch a little bit of this video. This is over the solid technique right here. Let me see if I can.
What I'm going to do is not only suction, but you're going to see me actually use this like a laryngoscope, where I push and lift. Now I'm compressing the tongue into the thyromental gap, and I'm distracting the lower mandible, so I'm actually opening the mouth. I'm going to use a hybrid sort of overhand insertion method, now the standard insertion. And now, as I'm going to release the pressure onto the laryngoscope, now I've got to view the hypopharynx. What I'm going to do is several very simple and easy to understand techniques in order to understand how to maintain airway decontamination. James, give me 3 pumps on the handle here. The reason I would want to leave the suction in during the intubation attempt is in the case of continuing airway contamination. If I'm not careful and I take the suction out, give me 3 pumps, 4 pumps, I'll have, that's it. I'll have a completely soiled airway now. As you can see on the video monitor, I can't see the larynx at all. This would be a completely blind intubation. So how am I to manage this? If I leave the suction catheter on the right side of the laryngoscope, it's going to produce a problem where I now have difficulty of tracheal tube delivery. How am I going to leave the suction catheter in the mouth while I do tracheal tube delivery? There's 2 sides to the blade. I'm going to take advantage of the left side of the laryngoscope blade. I'm going to remove the catheter and place it down the left margin of the laryngoscope blade. So James, give me 3 pumps on the handle. And as you can see, what's happening now is that my suction catheter is taking up the lion's share of the airway contaminant. My next maneuver to create room for tracheal tube
So notice how he
delivery,
has this in the
I call
esophagus and not directly above the epiglottis. That's getting rid of all the contaminants coming from specifically the esophagus and not necessarily pulling out the remaining oxygen inside the lungs.
Not too much unlike when you're placing central lines. You don't try to place a central line over a guide wire without dilating. Why are you putting a tracheal tube into a patient without essentially determining and establishing space for tracheal tube delivery? With the removal of the solid poke finger, I'm just going to place the bougie. The bougie goes in, the tail comes out of the bougie, and the tube goes in. If you're using bougies, it is quite possible to get away without a solid poke, but I think you're really asking for trouble, because you might have to use a stylet, or things just might not work out your way. As you can see, if I limit my space for tracheal tube delivery, what actually can happen is I can see what I want and I can't get it. That is like the biggest complaint with using video laryngoscopy. You can see it, but you can't have it. Why don't you do what we do in America? We have it all. We stick our finger in, and we get what we want.
I'm gonna pause that real quick. He's talking about a solid poke. What he's doing is he's sticking his finger inside the patient's mouth and kind of moving that laryngoscope blade over just to create room for the ET tube. That is completely up to you if you want to do a solid poke with your finger. I would recommend using a bite stick or something of that nature rather than just sticking your finger. I know we have gloves and things of that nature, but just a little tip for you.
Now I'm going to release the tail, and now I'm going to advance the tube. And the most important part of this that you'll see on the video monitor is if I place the tube just in the neutral position, I can't get it in necessarily because there's a left cut bevel on this tracheal tube. It is going to increase some space between the bougie and the tip of the leading bevel, and it's going to trap the right corniculate. The larynx is shaped like a gorgeous large mouth ice cream cone. It has a very large raised back portion, and it narrows to an anterior dished out and scalloped portion. If you don't left turn the bougie, I call this,
If y'all would just silence your cell phones, please, during the lecture.
I call it roll on the power. As you advance the tube, roll on the power. Yeah. What I can now do is I can trap the tracheal tube with my thumb, and I can take my own bougie out because I took my time and I rolled on the power.
So did y'all notice that he was talking about rolling on the power, the ET tube, his bevel right here? It could get stuck on the epiglottis or other anatomy surrounding the vocal cords. So what he did was just move that bevel in order to keep it from getting caught.
Now I have a contaminated airway. Do I want to ventilate this airway? I think I want to suction it before I ventilate it. So what I'm going to do is I'm going to go ahead and take my video laryngoscope out, and I'm going to run a flexible suction catheter down this tracheal tube. This is a nice, big, juicy 18 French suction catheter. The bigger, the better. Notice that I'm leaving the rigid suction catheter in and transferring it over to the flexible. Why did I do that? I'm not assuming I'm going to have a lot of help when I do this. And if I disconnect this prematurely, gravity, for some reason, increases its force during airway management and everything ends up on the ground. If I do it this way, I don't lose anything. And I place my finger over this, and I drain lungs, and I draw this out of the patient. And now, I can ventilate my patient. Inflate my cuff the whole bit. I should have inflated the cuff before that, but I'm not going to do that in this demonstration.
So yeah, he ended up suctioning out most of the contaminants in the esophagus, and then after that, after the intubation, before he started delivering breaths to prevent aspiration, he went ahead and suctioned out the tracheal tube as well. So that is it for this for now. Let's go ahead and get these mannequins and put it into practice.